apologize for the lengthy spirometric exercise. So it's always challenging to present a talk following after Corinne, and even more so when she's talked about pointless research, and I'm supposed to show my research. So no thanks to you, thank you. Okay, but really what I'd like to talk about today is the topic that I'd like to talk about is really about new public health approaches to support patients as well as caregivers, those who are seriously ill. And before I begin, perhaps just to put a disclaimer, there's really nothing new about the public health approaches that I'd like to share today. Much of this has been introduced even in the 80s, but perhaps just to set it as a counterpoint to some of the more conventional public health approaches that we are typically used to. So we know that whenever we talk about challenges facing patients with life-limiting illnesses such as cancer, neurodegenerative illnesses, so on and so forth, we normally think about things like lack of access to treatment or late diagnoses, so on and so forth. And normally our mind tends to jump very quickly to public health approaches that involve things like raising awareness. What are the measures that we can implement to prevent diseases, to prevent symptoms from developing, to improve quality of life. We heavily focus on conducting epidemiological studies, and then certainly at the end of it, we always aim to put more boots on the ground, so to speak, to establish more clinics, to build more hospitals, establish more services, in the hopes that the more we pump into this, the more access to care, access to treatment people will be able to get, and then their lives will be better. And certainly all of these are important, right? We keep asking the government to increase their funding, we keep asking for more doctors to be trained, more nurses to be trained, so on and so forth. We keep asking for more access to medicines, better epidemiological studies to better target these interventions, so on and so forth. So all of these are important and vital. However, I think increasingly there is also a recognition that we need another side of a public health approach. And these are approaches that focus on health promotion and empowerment in order for us to be able to increase the individual as well as the community's resources to be able to live and to live well, right? So rather than come from healthcare services, professionally driven approach, what can we do to further empower and to build resources within the community? And as I mentioned at the beginning, this isn't new. The Ottawa Charter since 1986 has also already started to emphasize that we need to look at public health not only in terms of providing more interventions and more healthcare services, but also start to think about how we can reorient healthcare services to expand beyond health professionals, be more multidisciplinary, yes, but also start to include the public and other lay expertise. We need to strengthen community action, develop personal skills among our patients as well as their caregivers, and to create supportive environments that not only support health but environments that can promote well-being. So many of these terms are probably familiar to most of you in the audience, and underneath the umbrella of these new public health approaches, you've got these concepts: health promotion, community engagement and participation. You've got asset-based intervention, so identifying what assets are already available in the communities that you seek to serve and build on those assets. Make use of skills and expertise that are already in the communities there. Consider how we can leverage on patient and community members' social networks in order to drive social change. Perhaps oftentimes invisible to us as people in healthcare are the very strong and powerful social networks that already have a great impact on the patient's lives in terms of social connectedness and the kinds of support that they already receive. And of course, you've got things like social support and compassionate communities and cities as well. Now, why do we need this approach? A couple of reasons. First of all, we know from literature engaging communities itself in our health projects will lead to improvements in health behaviors and consequences. But perhaps sometimes what is a bit less obvious, especially to healthcare professionals, is that sometimes we tend to see ourselves in the leading role, and we tend to see, perhaps that's why we entered into the caregiving professions. But more often than not, it's actually family, friends, and close community members who are the ones who are actually providing the majority of care and support. And to ignore them, and to think that we are going to be the cavalry to come in and save the day is often a misconception. We also know that try as much as we like, build as many medical schools, pharmacy schools, so on and so forth as we like, there will never be enough healthcare workers to meet the needs, to match the burden of disease within our communities. So therefore, we need to leverage on community. We need approaches that work to create, strengthen, expand, as well as to formalize all these networks of support in the community that are needed by patients and caregivers. And importantly, you want to do a lot of that work so that you can start to create repositories of knowledge and experience within the communities, and have communities become resources that can actually help us provide the care for people who are seriously ill. Because at the end of the day, our goal is not just to treat or cure illness. Our goal is actually to, at the end of the day, is to reduce suffering and to be able to build health and well-being. Now we know, at the risk of paraphrasing the WHO's definition of health, we know it encompasses not just the absence of disease, but complete physical, mental, and social well-being. And so when we want to build health in communities, we want to build health in people living in communities who are ill, we want to build among them the ability to adapt and to self-manage in the face of social, physical, and emotional challenges. And I recall I've had patients in the past who's, as a result of their illness, have become disabled, they've become wheelchair bound. And when we speak to them, oftentimes I can relate, one of them actually came up to me and said that, you need to teach me how to do my usual daily activities of living while on a wheelchair. Because if I can do those things on a wheelchair, I am not disabled. I am not impacted by my disease. I can have a better quality of life. If I cannot do those things, then yes, I have a disability. So you have to be able to build these capabilities within people as well. We also know health is a collective phenomenon. It's not just something that depends on whether you have an illness or not. It depends on your social relationships. It depends on the food you eat, the air you breathe, the communities you live and work with, right? So we know health services only contribute a minority percentage of health outcomes, and really the majority of it is determined socially and by the relationships you have. So a study published in PLOS Medicine, actually meta-analysis, actually highlighted various factors which might be able to affect health outcomes and mortality risk. And among things like smoking cessation, alcohol consumption, vaccination for the flu, cardiac rehabilitation, so on and so forth, what ends up being most impactful is in reducing mortality risk is actually social relationships. The stronger your social networks, the stronger the connectedness you have with your community, the stronger the support you get from your communities, the lower risk of dying. So introverts out there, you are at risk. And health is complex. This is what we call a horrendogram, because it's horrendous when you look at it, right? And this is merely studying the various factors. You can't see this and intentionally so, but this is taken from the Lancet paper from the Commission on Value of Death, merely focusing on one aspect, how to improve quality of life towards impending death. And you can see even then the vast majority of interlocking factors that are very much rooted in the community in patients and caregivers' families that come into play. So to imagine that you can introduce a healthcare service or public health intervention that is clinician driven or medically driven into this to solve all of this, I think it's a fallacy. So we know health, illness, and the experience of care and dying are complex and socially enmeshed. It's not a medical issue for you to solve clinically. Living with an illness like cancer, and those of us who are caregivers or cancer survivors will know this intimately, it's not a medical event that has a social component, but rather it is a social experience. Right? When you have an illness like cancer or family member has cancer, you know how your social connections change, your relationships with friends, family, community changes. So really it's a social experience with a medical component. And so it's an issue that has to be dealt with from the community and from society. We know cultural and community beliefs also have a big impact on how your experience of caregiving as well as illness will change. And as such, there is a strong need for a bottoms-up, grassroots approach, i.e. the new public health approach I've been talking about. We need this approach that really treats the community as an equal partner, not just a passive recipient of care, not just a passive recipient of services. And certainly when we say community-based, it really shouldn't mean just the location of care. All too often when we say we're going to deliver an intervention that's community-based, we often mean that it's based in the community. So community refers to the location. It really should be based on the needs of the community instead. So I just want to share quickly a study that we did, which just highlights again how important the need for community-based approaches are. So we did a long study, a 12-month longitudinal study in the district of Sagama with patients and caregivers who were severely ill. And we had multiple interviews, 4 monthly interviews with them over this period of time. And we intentionally did rather open-ended interviews, allowing them to drive the nature of the conversation, to explore issues that mattered most for them, focused around understanding the barriers and facilitators of implementing a community-based palliative care service. So to simplify this, really we had this idea that because in Sagama there are no palliative or supportive care services, there is therefore a gap in our public health provision there. The idea was that what if we built a palliative and supportive care service in that community there to meet that gap? Would the patients and their caregivers want this? And superficially on the surface, the answer seems to be, why not, right? You have people with cancer and other illnesses there. There is no palliative or supportive care there. The answer always seems to be, build one, right? So we spoke to them. What we find, some of our key findings, the first is, we debunked the whole build it and they will come myth. Because when we spoke to them, how would you like this service to be established in your community? The answer was, we don't want it. Take it back. Don't build this. Don't give us another healthcare service. Why? Because in the past, they've had experiences with healthcare services there where they've had indifferent doctors, which they've gotten bad experiences with healthcare providers, which now makes them skeptical or feel indifferent towards the idea of having yet another healthcare service to be offered to them. So their past experiences have shaped their future receptivity. They are less likely to want these services because of past experiences. And despite the model of the service that we wanted to build being very much evidence-based, very much being clinically sound, it certainly did not guarantee that the community would want it, or if we did establish it, it did not guarantee that the community would want to use it. And a quote from some of the participants was really that in the many experiences they've had of people coming to the community and offering aid, what they often offer is what is not what we need. You know, you give what is convenient to you. You give what you can give, or rather, you give what you think we need, but it's often not what we need. And when we spoke to them about, well, who would you like to get care from? Overwhelmingly, they preferred supportive relationships over support services. They want to be cared for by people who they know. They want to be cared for by people who they trust and people who they have relationships with, because there are issues around trust and safety, especially if they are already skeptical towards professional health services. There was a need, preference to be able to be cared for by people who could understand what their daily life was like and their issues without burdensome or embarrassing explanations. And being cared for by family or friends often means they get companionship, and this is something that they felt professional caregivers could not replicate. Family care was often seen as the ideal. It was seen often as non-transactional, and being cared for and being around family also meant that patients could often continue to preserve their identity and their roles. These were often stripped away from them after getting their diagnoses of illnesses, as they began to lose their jobs and their positions in society. So they start to lose their identity and their roles. But as long as they were with family, they could still be parents, spouses, children. Oftentimes they were still very much involved with being caregivers themselves for their spouses or their children who were also otherwise sick. And among caregivers, very much a cry for services that did not replace them. So they did not want services which would actually so-called take away the burden of caregiving from them, because caregiving was often viewed as a privilege, and as an opportunity to continue to express love and care for their family members who were sick. So they did not want that to be taken away from them. Granted, respite is always needed, right? But rather they wanted services and support that could help them with other things, finances, flexible employment, so on and so forth, that could allow them to then further increase their dedication to providing care to the people that they love. So on the issue of trust, of course, what we got from them was that if anyone were to come to their community to want to provide services to them, you must earn the trust at the community level, not just on individual patients. They wanted us to first gain endorsement from community leaders, as well as community groups. Their advice to us was that you need to begin early to start building relationships with the community first, before you start to want to offer services. So how do we know you care unless you show your care to the community by being involved in supporting community-led initiatives first, before you try to sell your services to us. Transparency about motives was essential. We wanted to know things like, again, what are you going to offer? Why are you offering this? Who are you getting funding from? Who is paying for this? And are you actually going to be here for the long run? Or is this just something that you're going to do to make yourself feel good? Several participants told us they've had experiences with charity reality shows, where the whole point was to be able to showcase people helping the poor and to make them feel bad about themselves. So they wanted to avoid all of this. So it's really, as healthcare providers, we need to be able to establish legitimacy and trust before we want to offer our services. So really, these are all the implications about why these approaches are needed. Again, health is fundamentally social, and so much of health is determined through social determinants. We have to respect that communities are the experts in their own needs, and that many of the structural barriers that they face to getting good care require structural solutions rather than clinical solutions. There are community assets which we need to begin as a starting point, because again, most patients and caregivers would rather get support from people they already know and trust in the community. And because of that, we need to co-develop services, etc. with them in order to further build that community capacity. All of this really in order to build greater community resilience through local ownership. I'm going to just skip past this, But just to very quickly give an example of a program that was established very much in the line of this community-centric approach, is really the Compassionate Community Connectors program established in Western Australia, where within the community itself, they train members of the public in the community to become what is known as Compassionate Community Connectors. And what these people do is they provide assistance to people who are affected by advanced illness and their family, identify what are their not only medical but social care needs, and then connect them to, not to professionals necessarily, but connect them to other lay people and community members in the public who have those skills and those expertise in the community to help provide care. So, and it can be for issues like personal care, preparation for end of life, but caring for pets, or for animal family members, provision of food, companionship, and isolation, and of course for transportation and home care as well. So these are also the other services that the connectors were able to connect people who are ill and their families to other members of the community for. And so they could connect to, let's say, people in the community who were legal professionals to be able to provide assistance for will, advanced health directives, etc. Connect to people who had access medical equipment so that they could loan equipment from each other. House cleaning, meal delivery, joining community groups. So they had patients who perhaps initially reached out to the connectors to say that I'm lonely, I'm starting to feel depressed because I have loneliness. They start to connect them perhaps to a morning walk group. People in the morning walk group then started connecting them to a group that had to do with dancing, and from there they started providing companionship to other people as well. People who were, let's say, helping out in men's sheds, which is basically like playtime for grown adult men who no longer have play dates. So you get a bunch of men together and then they start to give them some carpentry tools to work on, and hopefully in the midst of that they start to open up and talk about their emotions and play with themselves. So women in the group, if you have husbands who are not engaging with their friends, send them for play dates like this, right? So what they then found is before the connectors program, you would have, let's say, a patient right in the middle, and they would be at a spoke. They would have connections with family, a few connections with community, with their friends, and with formal services. But once they establish the connectors program, you can see how they become much more interdependent and intermeshed within community, family, friends, and services, whereby they are not only the recipient of these services, but they are also providing support to other members in the community, even as patients and even as people who are ill. Right? So obviously many benefits, many of which I've articulated already, but quantitatively, we found that significant savings from reduced hospital usage, less likely to get admitted to hospital, certainly less days in the hospital, less likely to use emergency department, and more likely to shift their needs from tertiary care to outpatient services. So final slide, I think with a new public health approach, what we do need is really to start shifting away from what we commonly do, which is we provide services and interventions to the community, which is where we have action, we implement it on the community. We also want to start moving away from doing things for the community necessarily, whereby they are merely passive recipients, and start thinking about doing things with and by encouraging the community to work together to do things that are by them for the rest of their community members. Okay. And with that, I thank you very much for your time.